Good morning, and thank you for joining us on our event for International Childhood Cancer Day. My name is Maria La Sierra Lozada, and we welcome you from the WHO Regional Office for Europe. Today, we mark this important day by launching a report that highlights the existing inequalities that we see across the WHO European region. To open this event, we will first hear from Nino Berzulli, Director of the Division for Country Health Programs at WHO Euro. Over to you, Nino.
Thank you all for joining us today for the launch of our report about childhood cancer inequalities in the WHO European region. Today, thanks to innovative technologies to improve diagnosis and treatment, up to 80% of childhood cancers can be cured. In well-served populations of high-income countries, cancer is not a death sentence for children and adolescents anymore. Unfortunately, however, this is not true across the WHO Europe region. Strong inequalities remain across and within the countries. We know that in some places, in some countries, survival from childhood cancer is as low as 20%. Last year, we launched WHO Europe United Action Against Cancer, bold movement from grassroots to governments. With this initiative, we want to act rapidly on the inequalities persisting in our region. First of all, because they affect children and young people, our future, but also because the inequality has been made worse by the COVID-19 crisis. Today, we are proud to launch a groundbreaking report about childhood cancer inequalities. This report is the first of its kind, and it brings together the evidence and information from a wide range of sources, presenting the nature and magnitude of childhood cancer inequalities in the WHO European region. It explores not only inequality across the countries, but also within countries across the different groups of population and according to social determinants such as gender, socioeconomic status, and urban-rural divide. The report also explores the impact of cancer as a cause of inequalities later in the life, looking also into how cancer produces inequalities by transforming the future of the child and its family. Of course, huge progress has been made on the front of innovations, and we celebrate those innovations that have led to childhood cancer patients experiencing better quality treatment and improved rates of survival. It is now time to renew our focus on addressing the inequalities, reducing the gap in relation to treatment and care so that we ensure a better chance for life to every child with cancer. I would like to now to invite Dr. Hans Kluge, WHO Regional Director for Europe, to speak further on this matter. Thank you, Hans.
Thank you, Nino. The improvement in childhood cancer outcomes seen in recent decades is an astonishing result of multiple medical and scientific achievements. A better understanding of childhood cancers alongside improved treatments with lower toxicity has led to a step change in how these cancers are managed. Yet, an array of factors can mean that in our region some children with cancer and their families have a poorer experience than others. Differences exist between and within countries in terms of the distance that patients have to travel for treatment, the extent of out-of-pocket costs, the availability of standardized treatment protocols, the access to medications and treatments, and the support and care that patients can receive in later life. COVID-19 has deepened already significant inequalities, notably by disrupting cancer services. In too many European countries, cancer diagnosis and care has been delayed, and backlogs have been piling up. More than 2 years into the pandemic, cancer in children and adults alike continues to be a compelling example of inequity in healthcare across and between countries. Given the scale of the problem, it represents a growing threat to society's economic development and social stability. WHO's European Programme of Work 2020-2025 is our overarching roadmap to deliver public health care, turning plans into action and outlining how WHO Europe can support health authorities in each member state. The Pan-European Cancer Movement, United Action Against Cancer, launched on the World Cancer Day last year, is part of this program of work. It seeks to control cancer and reduce inequalities in cancer outcomes and ultimately achieve the long-term ambitious vision of eliminating cancer as a life-threatening disease. This battle is more important than ever, and I firmly believe that lasting progress can be achieved, improving the quality of millions of lives.
Thank you, Hans. I would like now to introduce and welcome the Minister of Health of the Russian Federation, Mikhail Murashko. Thank you, Minister.
Dear colleagues, on February 15th, the world celebrates the International Childhood Cancer Day. On this special day, we talk not only about successes and achievements, but also remember those who are no longer with us today. At the same time, it is gratifying to note that the number of children that we have been able to help is increasing. In recent years, our country has managed to radically change and qualitatively reconfigure the entire system of medical care provision to children with cancer and blood diseases and significantly extend the use of advanced technologies. Today, the level of survival of children for a number of individual nosologies is over 90%. Success in treatment and the ability to live a full life primarily depends on the detection of diseases at an early stage. That's why we must do our best to provide unhindered access to the diagnosis and treatment of cancers. In Russian Federation, medical care for children in the field of pediatric oncology and hematology is provided in accordance with the regulatory legal document of the Ministry of Health of Russia, which approves the procedure for providing assistance to children, and this procedure is updated if necessary. It corresponds with the most advanced approaches to care provision for children with oncological and hematological diseases. A vertically integrated medical information system for oncology has been created, which allows you to quickly receive information about the diagnostics and treatment and control its quality at all levels. We implement managerial decisions based on evidence. The infrastructure of the service is being intensively developed. As a part of the implementation of the federal project for development of children's healthcare, including the creation of a modern infrastructure for providing medical care to children, measures have been taken to build and reconstruct children's hospitals. By the end of 2024, an additional 6 buildings in children's hospitals will be put into operation to provide oncological and oncohematological care to children, which will expand the possibilities for provision of specialized care, including high-tech medical care, create comfortable conditions for children to stay in medical facilities, including joint stay with their parents. This is also important for ensuring the quality of medical care for children. In recent years, diagnostics and treatment technologies using the latest medicines have been intensively introduced. A lot of work is being done to train qualified specialists, organization of specialized centers and departments. Modern technologies in medicines, such as bone marrow transplantation, are widely used. This allows us to improve the results of treatment and achieve a favorable course of an outcome of the disease. In the Russian Federation, all children with malignant neoplasms are provided with modern and high-quality treatment, and Russian and foreign protocols that have proven their effectiveness are used. The use of modern treatment protocols includes chemotherapy, surgical interventions, various types of radiation therapy, and cellular technology is also being introduced and used today. High-dose chemotherapy followed by autologous and allogenic transplantation of hematopoietic stem cells, immune and biotherapy allows us to achieve good results and save the lives of our little patients. In conclusion, I would like to express my gratitude to the WHO Regional Office for Europe for organizing this important event and wish everyone success in achieving their goals. Do not fall ill, be healthy, and be sure to get vaccinated. Thank you for your attention.
Thank you, Minister, for your address and commitments to improve the care and the treatment for children with cancer and implementing the innovative technologies and scaling up those innovative technologies in Russian Federation. Thanks a lot. And now we will go back to the studio.
Thank you, Nino, Hans, and Minister Murashko for those welcome remarks. We are now going to hear from Roberta Ortiz Sequeira, Medical Officer at WHO Headquarters, leading the WHO Global Initiative for Childhood Cancer. Welcome, Roberta.
Thank you, Maria. Good morning, good afternoon, and good evening to all esteemed colleagues. Thank you for the invitation to participate today in this very important event. I want to congratulate our colleagues from the WHO Europe Regional Office for this significant contribution to obtain a better understanding of the grassroots of inequalities in the access to quality childhood cancer services in Europe. These findings will inform policymaking to implement key interventions to tackle those inequalities towards achieving the Global Initiative for Childhood Cancer objectives, which are to increase country capacity to provide quality services for children with cancer, and to increase the prioritization of childhood cancer at the global, regional, and national levels. As we all know, the Global Initiative for Childhood Cancer was launched 3 years ago at the third UN high-level event on NCDs, as a response to one of the most profound health inequities, the significant survival gap existing between children living with cancer in low and middle-income countries and children in high-income countries. The World Health Organization Global Initiative for Childhood Cancer aims to improve outcomes for children with cancer around the world by increasing the survival rate to at least 60% by the year 2030, giving all children the best chance to survive and to live full and abundant lives while easing the suffering for all. 1 year ago, on International Childhood Cancer Day, the Cure-All Technical Package was launched. Actually, through the implementation of the pillars and enablers of the Cure-All operational approach, member states are advancing towards the stated target. 2021 marked the end of the first phase in the implementation of the initiative. Now there are over 50 countries actively engaging at different phases of country action. This has been possible through the multi-sectoral collaboration among governments, professional organizations, health facilities, civil society organizations, childhood cancer advocates, all working together across borders, sectors, and disciplines to contribute to improve access and quality of care for children with cancer and advancing towards the integration of childhood cancer into national policies and programs. Today, we celebrate International Childhood Cancer Day, and on this occasion, WHO, at its 3 levels, commits to continue working alongside our partners, many of which are represented here today, such as Sinju Children's Research Hospital, members from the International Society of Pediatric Oncology, SIOP Europe, Childhood Cancer International, childhood cancer survivors, advocates. Through our collective efforts, we continue this journey together to tackle health inequalities, delivering towards the achievement of the Sustainable Developmental Goals, and saving the lives of 1 million children in the next decade. Thank you very much.
Thank you, Roberta. Now, we will move on with Mary Lise, Senior Technical Officer at WHO Europe, and leading the cancer work here in Copenhagen.
Thanks a lot, Maria. And congratulations to you and Vitaly for putting this event together. You are really doing an amazing job and it's a great pleasure to work with you both. So the story is that thanks to a big grant from the Sinju Children's Research Hospital, we at WHO Europe have been able to initiate a lot of work on children cancer. And the more we were visiting the country of the region, the more we interact with our collaborator on that subject, the more we were struck by the inequalities between countries, but also within countries. So we decided we had to bring attention on it, hence this report. So we saw higher mortality, lower survival in some countries, in some subgroup, children never treated, children never even diagnosed. In Central Asia, for example, up to 30% of patients diagnosed with cancer among children are never treated. And when they are treated, it's on average 3 to 5 months after diagnosis, the time for the family to find the money to pay for the treatment, even if it's partly covered by health insurance. There are also big gender inequalities. In fact, for some biological reason, girls are a little less at risk of cancer and survive a little less better. But in some population and in some countries, it's the contrary. And when you speak to a Central Asian cancer registry and who explain to you that they see an incidence that is 4 times lower in girls, it means clearly there are some underdiagnosis and there is a problem. But let's be clear. Inequalities within country, they exist everywhere for gender and for socio-economical issue and for some other variables. For example, in Norway, a report cite a study who found that mortality was 15% less for children with highly educated mother. The reporter gives also example about Switzerland and other rich countries. So no country is immune to inequalities. Last but not least, in the report, we show data that to go through cancer is everywhere more or less an handicap for the rest of your life because of the physical and sometimes neurological impairment, because of the fact you had to be school for months or even years, due to the impact on the mental health of the whole family and the financial impact. And we see that in all countries of the region. The good news is that reducing many of these inequalities is highly feasible. And the report gives recommendation on that. It's highly feasible all the more since it doesn't require a lot of resource. At the end of the day, children cancer are quite rare, so it's kind of a cheap fix compared to other health problems to really tackle and improve situation for children with cancer. It's just a matter of political will. And at a time where economists all across the world tell us that inequality are not improving, with, for example, 50% of the European possessing less than 4% of the wealth of the region, and that, like in most places of the world, these inequalities are in fact growing, as it's well explained in the newly released World Inequality Report, it seems quite urgent to do something to reverse this trend, especially for health inequalities, and of course, especially for children with cancer. Thank you very much.
Thank you, Mary-Elise. Next, we will hear from Carlos Rodriguez Galindo, Head of St. Jude Global at St. Jude Hospital. Welcome, Carlos.
Thank you, Maria. It is truly a pleasure to be part of this important event as we recognize and highlight the inequalities that children with cancer face all over the world, but also in Europe. It is true that over the last several decades, we have made major advances in our fight against childhood cancer. In fact, today, a child diagnosed with ALL, acute lymphoblastic leukemia, which is the most common childhood cancer, and who can reach in a specialized center in Europe, has greater than 90% chances of being cured. And overall, more than 80% of children with cancer who live in high-income countries survive their disease. However, every year, about 400,000 children around the world develop cancer. Half of them die even before they are diagnosed. And of those who are diagnosed and can reach care, the majority die. So this is the crude fact. Today, despite the advances experienced in the field of pediatric oncology, 80% of children with cancer in the world die. And this is the crude reality. The most important prognostic factor that will determine if a child with cancer lives or dies is where the child was born and how our society responds to protect the lives of these vulnerable children. So recognizing these disparities is the first step towards addressing them, and we are very thankful to WHO for creating this opportunity for dialogue and action. The Sinju Global Program that I lead was created under the vision that every child with cancer should have access to quality care, and we work with partners around the world to develop strategies to address these disparities through training programs for the clinical workforce, through the development and strengthening of the health systems and patient-centered initiatives that encompass the entire continuum of care, and also through advancing local and regional research capacity to sustain continuous improvement. As a WHO Collaborating Center for Childhood Cancer, we are proud to work together with many partners around the world in support of the WHO GICC that Roberta leads, a true global movement to ensure the right to cure for all children with cancer. So I believe that it is only through these comprehensive programs that bring all the stakeholders together that we will be able to address the global, regional, and national disparities in access to care and outcomes for children with cancer. The WHO European report on inequalities in childhood cancer comes to fill a very important gap and represents an important first step to ensure that all children with cancer have the best chance to survive, wherever they live and whoever they are. So thank you, and back to you, Maria.
Muchas gracias, Carlos. We are truly grateful for all the support that St. Jude has provided WHO. We will next hear from a very special guest, Erin Anderson. Erin is Cancer Ambassador for WHO Europe and has experienced firsthand the benefits of having access to high quality and to a supportive healthcare system. Welcome, Erin.
My name is Erin Anderson. I was first diagnosed with cancer when I was 7 years old. I am forever grateful to the nurses and doctors at the hospital, to my family, to the access I had to some of the best care in the world, to the best medications. And I'm forever grateful that I'm alive. I was extremely lucky to survive cancer. On International Childhood Cancer Day, my thoughts are with the families of children whose cancer will go undiagnosed and untreated because of barriers. Barriers such as access to basic technologies like CT scanners, of cancer medications, and geographic distances. Today, as we launched a WHO European report on inequalities in childhood cancer, I'm adding my voice to call on those responsible for policies that impact children with cancer and their families, and that can influence the inequalities they experience. I call on these people to urgently act. We cannot continue to leave families facing impossible choices, such as whether to seek diagnosis and treatment for the sick child or to avoid financial catastrophe for the family. We have so many solutions to prevent childhood cancer deaths. Some countries have paved the way, increasing survival rates from as low as 30% all the way up to 80% and higher. But this incredible progress has not been realized equally in countries across the region. The disparities are massive, so the solutions are there. This is low-hanging fruit. What do we need then? Well, we need better data. Better data so we can target our investments where it will make the most difference to children with cancer. Basically, it's more about how to spend public health money better. We need free of charge diagnosis and treatment. This is vital as childhood cancers are aggressive, and getting a diagnosis and adjustment treatment plan in place quickly is essential for survival. Finally, we need adequate training of healthcare professionals so that they recognize the signs and know how to deliver effective care. We know policymakers have been firefighting COVID. We know that. But we also know children with cancer cannot wait. I urge you to read this report and to act on its recommendations. Thank you.
Thanks, Aaron. It's important that we document the existing inequalities, but equally important is to provide solutions and recommendations so that policymakers can take action to improve the situation. Helen Crump, author of the report, will explain to us what are the key actions that can be taken forward. Thank you, Helen, for joining us.
Thanks, Maria. In producing this advocacy report, the team were keen to ensure that we identified as many potential solutions as possible to enable decision makers to consider a full range of options for reducing inequalities in childhood cancer in different health systems. The recommendations we've made represent positions that we hope all countries in the region will aspire to achieve. But it's really important to recognise that each country is beginning from a different starting point and will need to take different contextual issues into account. Recognising these points, we hope that decision makers in all countries in the region will be able to find something of value in the recommendations that we've put together. Following the structure of the report, we've grouped recommendations into 3 categories, one focusing on ways to reduce inequalities between different countries, one focusing on addressing inequalities within countries, and finally a category focusing on inequalities affecting childhood cancer survivors. An area of key importance in reducing inequalities between countries relates to realising the World Health Organization's goal of achieving universal health coverage. For childhood cancer, this would mean aiming to provide universal health coverage at a national level to cover all cancers in children and ideally also young people. Linked to this point, minimising the use of out-of-pocket payments as a means of financing treatment for childhood cancer is also highly desirable as a route to improving equity. We can support parents and carers who need to look after children with cancer by ensuring that in each country in the region, provision is put in place to allow parents and carers to take leave from work to look after the children they care for. We also need to make sure that across the region, data on childhood cancer is of sufficiently high quality to give us a clear picture of how many children and young people are being affected and what their outcomes are. We can achieve this by ensuring wider use of population-based cancer registries using internationally agreed classification systems. These should incorporate outcome and staging data where possible. Thinking about reducing inequalities in childhood cancer within countries, we must make sure that in all countries, marginalised and seldom reached groups are able to access childhood cancer services as easily as the rest of the population. This should include both documented and undocumented migrants. We need to support families to understand their rights to treatment and to provide them with information on how to navigate healthcare systems so that they know what they need to do in order to access the right care. One relatively straightforward step that could make a huge difference to some families is to ensure that when a child with cancer is staying in hospital as an inpatient, that child's family has somewhere nearby to stay. This has the potential to make a big difference in situations where children have to travel some distance in order to access specialist care. Finally, there are many ways that health systems can work to address the inequalities faced by childhood cancer survivors. There are big gains to be had by supporting survivors of childhood cancer to achieve a smooth transition between children's and adults' healthcare services, and making sure that access to digital medical records is straightforward using schemes like patient passports. We can do more to address the physical, psychological and socio-economic consequences of a childhood cancer diagnosis, both in the short and long term. And we can ensure education facilities are always in place for children with cancer, both in hospital and in the community, so that they're able to maintain their educational progress as much as possible. Once again, there's a need for better data in relation to childhood cancer survivors. We can do more to collect data on long-term outcomes. And if we put appropriate consent processes in place, we can achieve a further benefit by supporting more research on the long-term health status of childhood cancer survivors. We hope these recommendations will be of use to those people in member states whose role is to reduce inequalities in childhood cancer. We believe that while the task is challenging, the potential gains to be had by addressing the inequalities faced by children with cancer in the European region are compelling. I'd now like to hand back over to Maria.
After having heard about the inequalities that exist across and within countries in the WHO European region and what we can do to ameliorate them, we're going to hear from our wonderful panelists to further engage in this conversation. We are very lucky to count on Sarah Bosley, former health editor of The Guardian, to lead this discussion. Over to you, Sarah.
Thank you, Maria, and thank you, WHO Europe, for inviting me to this very important event. I'd like to introduce the 6 panelists that we have today. There's Dr. Joachim Schutz, who is head of the Environment and Lifestyle Epidemiology branch at the International Agency for Research on Cancer. Ms. Anita Kienersberger, chair of Childhood Cancer International Europe. Professor Gilles Vassal, head of the Pediatric Research Programme at Gustave Roussy Comprehensive Cancer Centre in France and SIOP Europe board member. Dr. Frederica Erdmann, head of the German Childhood Cancer Registry. Ms. Bano Abdusamatova, Vice Director of the State Child Support Foundation under the Uzbekistan Cabinet of Ministers, and Professor Olga Alenikova, Director of the Division of National and International Health Projects at the Rogachev National Medical Research Center of Pediatric Hematology, Oncology, and Immunology. So the first question is for Joachim. We heard from previous speakers that there are major inequalities between countries when it comes to childhood cancer. And obviously at IARC, you measure the childhood cancer incidence and mortality in every country in the world. Can you tell us some more about the scale of these differences and the reasons for them?
Yeah, thank you for this question. And clearly, I start with a global perspective as the Cancer Research Agency of the World Health Organization. And here I have the bad news that the survival gap could hardly be wider. So it's really bad news. And this is because the inequalities exist throughout the entire journey of childhood cancer, starting with the awareness that in parts of the world, it's really difficult to identify the symptoms that would raise this awareness that it could be a childhood cancer. The specialized cancer centers are difficult to reach, so the referral is also already an obstacle. The diagnostic process is very difficult. Because you don't have the facilities everywhere. And also sometimes in many parts of the world, the resources are not there. And especially when families hear about the resources needed for the treatment, then many never return to hospital and actually a diagnosis is never made. And then, of course, the treatment where we also have, major disparities all around the world. So it starts actually with the fact that the numbers are hard to get. So when we estimate of how many childhood cancers we have based on what is registered in the cancer registry, then we come up with numbers that are a bit more than 200,000, around 220,000 per year. But we think that actually the true occurrence of childhood cancer is much higher, almost 400,000. And this shows already what large percentage worldwide does not have a proper diagnosis or does not have a chance of treatment. And this is why also families do not seek this diagnosis. If you look at Europe alone, the situation is still unacceptable. The survival gap is not as large, but we still have disparities around 20-30%. between countries. And it also depends very much on the childhood cancer type. We shouldn't forget that childhood cancer is really a mix of very different diagnoses. So while there's very good treatment successes in the past decades for like the lymphoid leukemias or the lymphomas, we do have, for instance, specific types of brain tumors, where even in the top countries with the treatment, it's still a challenging diagnosis and more work has to be done. But yeah, in summary, we also, have to guess a lot of numbers because many parts of the world and even in Europe, there's gaps in registration of cancer. So this is why all these numbers have some uncertainties. And the agency has therefore also started an initiative to actually move childhood cancer registration forward, because for all our decisions, all our monitoring, all our planning, we need, of course, these numbers to make informed decisions.
Yes, I'm assuming that data collection is a very big issue here, and perhaps we'll come back to that. Can I ask you, Gilles, to come in here and talk about treatment outcomes, which are very different between countries? Can you tell us why that is? Is this to do with access, or is it cost, or is it the quality of the treatment that's available?
So thank you for the invitation. I think the main issue of inequalities are the three topics you mentioned. We need to consider that treating a child with cancer is complex, multidisciplinary activities, and we have more than 60 different pediatric cancer to treat. And the issues explaining the inequalities are, A, there are inequalities in the capability to deliver quality care, which is making the right diagnosis and the right staging through pathology, biology, imaging, to make the right decision on which treatment should be delivered to a child. And this is the need for multidisciplinary discussion through tumor board, which is something absolutely as a hallmark in pediatric oncology, all together discussing the case of a child in order to best define which treatment should be available. Second, defining the standard of care of these patients. And this is important. And this is an initiative that is being developed by the SEIOP Europe and the European Reference Network on Childhood Cancer, Pediatric PETCAN, to build and make available standard care protocol for each of the different disease frontline, which means that the team will have access to what is considered as standard of care across Europe. And when we say Europe, it's not only European Union, but the European countries. But then delivering of the treatment needs also capability. Chemotherapy and medicine are essential. And for some disease like leukemia, it's the only treatment, complex treatment, multiple chemotherapy, combined chemotherapy over several months of treatment. And the access, availability, affordability to these essential medicines, as defined by the WHO Essential Medicine List, is clearly not across Europe for all patients. And for example, we made a survey looking at the shortages, and we found out that the shortages are in this essential medicine are different across Europe. And country with a low global national income per capita has a higher risk of shortages. So access to medicine that are considered essential is absolutely crucial. And this is why we say all children, especially in Europe, should have access 24/7 to essential medicine for being treated with cancer. But it's not only chemotherapy, it's only surgery, it's also radiotherapy, and access to expert surgical teams and the radiotherapy device is also extremely important, especially for the treatment of solid tumors and brain tumors. So you see, and access to that is something which is not equal across Europe because of the lack of the capabilities, the lack of availabilities in some situation of these tools for treatment, which are essential. And finally, I would say training is absolutely important. Training the health professional in order really to be able to best deliver care and treatment through these guidelines, the SCP I was mentioning, which is a really advanced to be sure that all children can have access to a standard treatment. And this is clearly where in Europe, we are very lucky with the cross-border healthcare directive, which is there to facilitate cross-border care for a child who would need very specific surgery, which cannot be able in all countries. So we are very lucky that this directive is there, but still there are discrepancies. As mentioned by Joachim, even in Europe, there are a probability of 20 or 30% difference in terms of overall survival for children across Europe. And this is why the European Reference Network on Pediatric Cancer, ERN PEDCAN, in partnership with SIOP Europe, is really working on tackling these inequalities. And in the training, for example, we are developing training programs to train institutions really to improve the quality of care, train the health professional, and be in a situation that the inequality will be tackled. So we understand the inequalities across Europe and even more at the global level. We know what is the target, and there is a real need to invest at the national level, at the member state level, to assure that every child will have access to what is considered at the moment the best treatment that is able to cure 80% of the children in terms of 5-year survival.
Thank you. Fantastic aspiration there if we can do that. Frederica, can we move on to inequalities within countries? And I know your group has done a lot of research on this. Can you tell us something about the nature of those inequalities within countries and the scale of them?
Thank you so much, Sarah. I've indeed collaborated with many colleagues and groups from different European countries about this important issue. So what I find most important to stress here, since I see here the greatest potential for any action or a strategy to improve the situation, are inequalities in survival. So not all children benefit equally from the recent diagnostic and therapeutic improvements, and large survival disparities have not only been observed across countries, as just Joachim mentioned, but also within countries, including European countries. These survival inequalities concern socioeconomic background, gender, geographical region of residence, and even family conditions. So lower survival has been demonstrated for children of families where parents have short education, low income, are single, and have poor living conditions compared to children from families which are better off. The role of gender as a driver of inequalities in childhood cancer appears to be very different between high-income countries and low-middle-income countries. In high-income countries, boys with cancer tend to have worse outcome than girls. However, this seems to be explained mainly by biological reasons, whereas data from low-middle-income countries suggests that girls with cancer are substantially underdiagnosed. And there's only limited evidence, but it seems that also geographical region of residence and distance from cancer facilities play an important role in inequalities. And finally, there are also some suggestive evidence that family conditions like parental cohabitation or a number of siblings play a role in generating inequality in childhood cancer outcome, although research is very limited on this topic and the relationship is not very clear. But having said all this, for me, it's very important to stress that the knowledge and observations I've just summarized mostly derive from countries with high positions in the Human Development Index, including quite some research observations from the Nordic countries. And those are countries with the lowest level of inequality. And there is, in fact, very little data about the situation of countries with lower socioeconomic development. However, we do assume, we have the strong assumption that inequalities in those countries are even much more pronounced. Yeah, and lastly, before actually giving back the floor, I also want to briefly touch up on childhood outcome in refugees and migrant groups. There's again very little evidence, scientific evidence on this topic, but I'm aware of one study from Finland which found considerable worse survival for children with a foreign background or whose parents are migrants. And moreover, children of migrants tend to use general care, primary care, and oral health care service much less than non-migrants, but using emergency rooms and hospitalization more frequently. Fortunately, the health of refugees and migrants is increasingly recognized, and also I consider this issue of considerable public health relevance. So in Germany, almost 40% of all children have a migration background today. So that's why I think it's a very important topic to tackle also in the future. Thank you.
Thank you, Rita. Can I turn to Barno now and ask, what are the most pressing inequalities in low and middle income countries? And what can those countries do to tackle them?
Я хочу поприветствовать всех наших коллег сегодняшней дискуссии.
I would like to welcome all our colleagues to today's discussion. Today's topic is very important topic for Uzbekistan as well. I am the Deputy Director of the Public Fund for Supporting Children in Uzbekistan, which was the structure subordinates to the Cabinet of Ministers. This issue is also considered a priority in Uzbekistan because you all know that in Uzbekistan the population is increasing year after year and the number of children is also growing. And also, in our statistic, year after year, the number of children who become patients is also increasing due to the population's growth and due to their detection by screening. At the primary level, we now have a children's department that conducts very thorough, good screenings and reveals the real incidents. And therefore, at this moment, Uzbekistan has only joined the treatment approach standards according to WHO standards. Exactly what do I mean by this? This means that we had separate specialization of oncology and hematology for children since 2021. I would like to inform you that we have combined these specialties and we have, according to the decree of the president, now we finally have the presidential decree that these specialties, pediatric hematology and oncology, has been merged. And what happened before? Our problem was either that children with oncological diseases and hematological diseases were treated separately and they were treated only in adult hospitals. There were these problems in remote areas as well, in the regions, and there was a shortage of specialists. And there were also oncological dispensaries and in children's institutions and hospitals in remote areas, there were hematological beds or wards that were treating anemia and severe blood diseases. Since 2020, we have combined these specializations and we began to work according to the WHO standards. And also, was the problem that you have mentioned before, specifically regarding medicines, we also had the specialist issue that we shared together. And the fact that the families who did not reach out in early stages and who were not aware, we also had these problems. And the most pressing problems of ours were mainly in the field of strengthening the administrative organizational structure and providing equipment and materials. There was no integrated vertical system. In the field of human resources for health, these were the scientific potential issues and application of modern practices. There were a few not plentiful scientific studies specifically related to the child population, children morbidity in Uzbekistan. There were also medical equipment in the field of providing medicines, and there were also problems with the necessary consumables, providing medicines for children with hematological diseases was an average around and up to 30% of ones with cancer, and 85% are for one course of children with hematological diseases. We did not cover medicines for a period of 2 years. In total, up to $10,000 are spent for one course of treatment for oncological patients, which was usually 7 to 10 days, which was up to 4 million Uzbekistani soms out of the state budget. In these medical institutions of ours, in which patients were treated, educational, practical, and scientific laboratories were established at a proper level. The share of diagnostic equipment in modern laboratory was about 45% from total. So the state undertook this, and we adopted a resolution of the president and the resolution of the cabinet of ministers. And now, starting this year, we have created a children's oncohematological center that treats only specifically children. And now we are working in the field of international cooperation with international organizations and various clinics in other countries. Now, at the moment, we have problems precisely because we have this new direction in oncohematology. We are working on the human force for health provision, providing the material and equipment needs, and also providing medicines as well. Therefore, we have a big road and tasks ahead of us for Uzbekistan and for the population. But we have already taken a big step forward. And so I want to proudly state that until today, there was no such center in Uzbekistan. And this center was open under the chairmanship and on behalf of the president. The Center for Pediatric Hematology, Oncology, and Clinical Immunology has been operating since January 1st of 2022. Therefore, we have very big tasks ahead of us, and so that in remote places for the population, it was much easier for children to encounter and to go to the doctor and to get treated timely. We organized departments of oncohematology for 20 beds in regional structure, and in some of the places for 15 beds. This means that we have combined the Department of Hematology and dispensaries that have existed for children oncology into one structure, and have created a Department of Pediatric Oncohematology. And in the same perspective, we have formed a vertical service model specifically for children whom we will treat, care, and help. Generally speaking, we have a very big task before the state and the government and before the population, because as you've just heard, we have a completely new direction. There are no standards of treatment in place. We have to work on them now. We've already organized and established a working group together with the WHO representative in Uzbekistan and other ministries involved in the care continuum. We made a roadmap till 2025, and we are currently working both with international organization and NGOs and with ministries involved in the care continuum.
So I wanted to ask you, Anita, about the third inequality, which is that suffered by children who have cancer, and then they actually suffer from physical but also mental and social problems later in life. So perhaps you're chair of Childhood Cancer International Europe. Maybe you can tell us about this and help us understand what the cancer patients and their families go through.
Thank you very much. This is really from the bottom of my heart, because survivorship is one of the main areas we are focusing on. And
as you already said, it is a long life journey. It's not, patients always say, if it's over, it's not over. It's something what we have to realize. They have to undergo treatment, what is toxic. It is, I mean, they survive, but 2/3 of the patients have long-term effects, physically and mentally. And sometimes because the physical side effects are so severe that you don't realize very soon after the therapy that you have mental problem as well. So I think what we have to do and what we have to focus on, and we found out together also always with SIOB, to really focus on long-term follow-up care throughout Europe. And you would not imagine that it is also in the rich countries not available. So, of course, I mean, 40 years ago, children with cancer did not survive. Now we have achieved that 80% survive. But nevertheless, we didn't know how toxic this will be, this treatment, for these children. They were very young and they didn't know about it. We all learned from year to year. And this is what we have to do with a generation that had cancer and they are now in their 20s and 30s. And they realize now what does it mean to live with a life after childhood cancer. And it is not, I think it's not dramatic, but it is not what we have. And they are not suffering because of, they said, oh my God, it was so bad to have, I had cancer in my life. But we have to take care about that. It has to be something what is really, we have to work on, that it's available, that every childhood cancer have the right throughout Europe, not only in the rich country, also in the widening countries, to have access to a long life after care treatment, really long, lifelong. And I wanted to say, to mention something. Many survivors are saying, I'm lost in transition. It's a term, but I don't want to say it as a term. Transition is a very important thing. And if we train the young patients very soon that they have to take care about their future life, and if we make them aware that this is their own health, we guide them, but it is something where we really have to focus to educate them, that they really understand they have to live with side effects, and maybe future innovative drugs don't make these really severe side effects anymore. We don't know yet, but we also look now what these side effects could be in future. So what I wanted to point out is really not letting them being lost in transition, because if they are kicked out when they are 18, most of the time from their pediatric hospitals, then they have such a big history in their hand, and no one really want to take them, because this is something what you have to really be educated in. What does it mean to treat a patient with long-term side effects? So very few countries have this in place, but this is one of the main issues we have to work on, that this inequality has to be diluted from. This is everything what I wanted to say now.
Yes, thank you very much. You're very clear. Olga, perhaps I could bring you in as Director of the Division of National and International Health Projects at the Rogachev National Medical Research Center. Maybe you can tell us what's being done in your country to help children with cancer have a benefit from as good a life as possible after they've recovered from the disease.
Спасибо огромное в первую очередь за то, что меня пригласили, нас, вернее, пригласили.
First of all, thank you so much for the invitation, or rather for inviting us to participate in such an important event. Yet again, first of all, I would like to say that the situation around this problem has significantly improved in the Russian Federation over the past 20-30 years. This situation was the survival of children with malignant neoplasms, childhood cancers. And today, the survival rate are in line with the European average on and for literally all types of childhood cancer. And thanks to the fact that 10 years ago, the Dmitry Rogachev National Center was opened with technological capabilities corresponding to the most outstanding standards of medicine today. And access to this medicine, access to this center is available to all children of the Russian Federation, regardless of where they live in Vladivostok, Kaliningrad, or Chechnya. So, this, of course, all led to the fact that the situation with childhood cancer improved significantly. But, as the previous speaker just said, that health is the general health. And this is also what the WHO is talking about. It stands on the three pillars, which is physical health, mental health, and social health. Which means that there are, of course, inequalities in physical health and social and mental health because they have overall health, or rather, the sick have inequalities compared with the healthy in all those three areas. But I would like today to talk about, since a lot already has been told about physical health, I would like to probably dwell on inequalities in the field of social health. Because when a child gets sick, first of all, the whole family becomes so-called codependent. These are the second children, which is brothers and sisters in this family. These are the parents, of course. They also cannot be called completely healthy, since the fact that they suffer socially and psychologically a lot. And of course, the children themselves who end up in a clinic for a long period of time and are forced to be hospitalized for several months. And it is very important, especially for school children, when they are cut off from their environment, when they left their classes, when they left their friends, and they have to stay in the hospital for a long time with all its troubles or conditions of hospitals. And it's very important not to fall behind your peers. And we try to solve this problem in the Russian Federation in the following way. We had such a project 10 years ago, and it is called the Hospital School We Teach They Learn. In English, this acronym or abbreviation is We Teach They Learn, to make it easier to translate and how it sounds in English from Russian. This school is inspired by Professor Sergei Sharikov. This means that special teachers, tutors who accompany these children during their entire stay in the clinic are being prepared and educated. The children do not lag behind school curriculum. The children receive a huge social, I would say, advantage over healthy people, because if you just saw how many events are taking place within the framework of this school we teach, they learn, very famous artists of the Russian Federation come here to visit us, various seminars are held, and most importantly, these are events for children, which are the Christmas holiday celebration. These are all holidays that they are celebrating on such a grand scale that I sometimes think when I see these children happy, are they in the hospital? Are they being treated or entertained? Or did they just come to us in order to get some additional pleasure from the fact that they come to Moscow, to this clinic, and are in this clinic in the hands of these tutors, teachers? From the school we teach, they learn. And naturally, this experience was very much supported by the government of the Russian Federation and was quickly distributed to all regions. Today, there are already such schools in 45 regions of the Russian Federation. And we also participate in international activities. We are trying to spread this experience to other countries and especially to the CIS countries. And today I can say that the same schools have appeared in Armenia, Azerbaijan, and in Kyrgyzstan. since last year in Uzbekistan, we have also started to carry out this project. And they enjoy, well, colossal love that we receive, first of all, from children and their parents, and of course, from doctors. And therefore, that is much easier to treat a child in a good mood than when he has withdrawn into himself, or when he is very upset that he has lost friends. And here he finds new friends and mentors as well. And I believe that this is also a social aspect that eliminates inequality between healthy and sick children. And these children not lagging behind in their school knowledge, then they can in the same way get a profession, they can go to universities in the same way as others, and this inequality is being smoothed out precisely in the social sphere. I'm not talking about the fact that, of course, in all countries of the Eurasian region, it is necessary to introduce the standards for the treatment of childhood cancer adopted by the WHO. And I would like to voice another project that is now underway in all countries of the Eurasian region, in which I also once took part in its creation, which is the project Urado, project led by the St. Jude. There are two founders, which is St. Jude Hospital in Memphis, United States of America, and our Dmitry Rogachev Center in the Russian Federation. Today, there are a huge number of different sub-projects in this one large project, where all our colleagues from all these countries of the Eurasian region and also from Uzbekistan, Karakol, Pakistan participate. In general, there are not many pediatric oncologists, and we all know each other and are friends. And I think that thanks to our efforts in the future, we will reduce the inequality between the healthy and sick children in all areas. Thank you so much.
That's really fantastic. So good to hear these wonderful things that you're doing. We're very short of time. Everybody has such a lot to say. I'd just like to go back to Joachim just very briefly to ask him if there's anything we can do to prevent childhood cancer in the first place. And can you make it 20 seconds? No longer. Thank you.
Wow. Okay, that's a challenge, but I think it's a very important question. I mean, we heard from Jill about the struggling with the optimization of the treatment. We heard from Anita of all the challenges in the aftercare of childhood cancer. So of course, ideally, we would want to give some guidance of how you reduce your risk of getting childhood cancer in the first place. But unfortunately, unlike for many adult cancers, we cannot give such a clear guidance because we have not really identified any major modifiable risk factors to reduce the risk of childhood cancer. And I mean, we know about a few genetic conditions, factors related to reproduction, but we cannot modify them. There's fortunately some factors that are good for child health anyway, and also appear to have a positive effect on childhood cancer, like folic acid supplementation of the mother during pregnancy, or breastfeeding, or specifically not smoking even before conception. Well, the good news is that we have a lot of initiatives, so researchers don't give up. But unfortunately, it may be a long, rocky road. And this is why, specifically for childhood cancer, it is so important that we continue all these strategies that are laid out for improving treatment, because it may be for a while that we have to rely on treatment for giving these children a future, and also for reducing the inequalities in Europe and around the world.
Thank you very much. That's a very good try, a good attempt within the time frame. Thank you, everybody. It's been really interesting, really exciting to hear of what you're doing. And now I'm going to hand back to Maria.
Thank you, Sarah, and dear panelists, for such an engaging conversation on these important topics. To conclude this event, we will hear back from our regional director, Dr. Hans Kluge. Welcome back, Hans.
Many thanks to all speakers and panelists for your interventions and contributions to the discussions. These rich discussions and the report we have launched are helping to move both the childhood cancer agenda as well as the health inequality agenda forward. This report is one of numerous activities that are part of the WHO European Programme of Work and contribute to effective, stronger and more resilient health systems where public health action and appropriate public policies secure better health outcomes for all, leaving no one behind. While the COVID-19 pandemic has been a shock to the system, it has always shown us what we are capable of when we are united in the face of a common threat. Together, we can significantly reduce inequalities in childhood cancer. The report before us provides concrete steps that can be taken now to make a difference, even with limited resources. WHO is stepping up to the challenge, scaling up efforts to assist countries in tackling childhood cancer. And I warmly thank you for joining us in this movement.
Thank you, Hans. What a great way to conclude today's event. I want to thank everyone who has joined us today, our audience, our panelists, and our speakers. Thank you for your time, and especially for your commitment to help fight the inequalities in childhood cancer that prevails across our region and around the world. We hope that with all the information that has been shared today and with the launch of our report, we can bring attention to this pressing issue and move ahead together to give children a better chance of surviving cancer, regardless of where they live. Thank you.